Hey, good morning, everyone. Welcome to our last ground round for the year. I'm Dr. Brian Power. I lead the Mood Disorders Unit here at Hollywood, and we've got Dr. Leighton Chadwick, who's in-house today, and we have an online audience as well from around Australia. And before we start, I'd like to recognise the Whadjuk people of the Noongar Nation, who are the traditional custodians of this land on which Hollywood Hospital stands, and pay our respects to elders past and present. As you know, Dr. Chadwick is a locally trained psychiatrist. He is the chair of the Psychiatry Advisory Committee here at Hollywood Private Hospital. He's got extensive experience in both the public and private sector across 2 decades, and he works here full-time at Ramsay Clinic Hollywood, leading our eating disorders unit. And although he doesn't like to admit it, I think he's now an expert in eating disorders. Anyway, so today he's going to be presenting an update on a really interesting topic. So really quite focused, neurostimulation treatments in eating disorders. Please welcome Dr. Leighton Chadwick.
Thank you, Brian. I guess just a little bit to set the scene a little bit, what I and the team do at Ramsay Clinic Hollywood. I'm more recently in my professional career become the psychiatrist attached to the inpatient eating disorder team. And we have 10 dedicated beds. We take patients 16 years and older. Predominantly they are patients with anorexia nervosa. Broadly, these are people who haven't responded well to out-of-hospital treatment or have suffered medical compromise, early medical compromise as a result of their eating disorder. I'm proud to say that our dietitian Taz is here today. Our clinical nurse Nat is off on sick leave. Our registrar Kian is here. Our RMO Vicky is up the back. We have quite a big team, as well as very experienced nurses on the floor in our ward who all have wide experience in managing patients with eating disorders. Despite what Brian said, I'm not an eating disorder expert, and I don't treat any eating disorder patients effectively in my outpatient clinic. I guess I came to eating disorders quite late in my career and already have a huge outpatient cohort. It's very difficult to fit patients with eating disorders into that cohort. And as soon as you put your head above the parapet and say you work in eating disorders and outpatients, your inbox is full of referrals. Don't do any research either. I kind of feel embarrassed to say it now. I used to say it proudly, but now I kind of feel slightly embarrassed. I rely on other people with expertise in research to do the research, and clinical academics. Obviously, what we do in psychiatry is hopefully increasingly based on what is research-based evidence. And as a clinician, I ride on the shoulders of people who do research. So this presentation is a very broad topic. I tried to cover it fairly broadly. I know there's a very mixed audience, so I hope I don't pitch it too low or too high or too left field. I'll talk a little bit about neurobiology. A little bit about neurostimulation to treat the depression so commonly comorbid in eating disorders, and that's probably its main clinical role at the moment. A little bit about how neurostimulation might actually be a primary treatment for the eating disorder per se. A little bit about how we do practically ECT here at Hollywood. And I'm not really going to talk about all that wider eating disorder stuff, but equally important, if not more so, the principles of refeeding, medication management, psychological therapies, relapse prevention approaches. So briefly, what is neurostimulation? I'm going to be talking about electrical and magnetic stimulation techniques, broadly into sort of 2 main categories, non-invasive and invasive. The non-invasive, if you like, ECT, certainly non-invasive transcranial magnetic stimulation, and certainly non-invasive direct current stimulation, which we'll probably see a lot more of in the future, given that another device has just received Therapeutic Goods Administration approval for marketing in Australia. So the goal of neurostimulation is to, at a biological level, broadly speaking, restore functional neuronal activity and connectivity. It does a lot more besides that as well. Brian kind of said to me when I was doing this, well, you're going to talk about esketamine and psychedelics, and I sort of deliberately excluded them. I guess if we strictly look at neurostimulation as a definition, they probably don't meet that criteria. But they're a very interesting group of treatments in eating disorders too, and in depressive syndromes. And that would be, as we saw last time in this meeting with John Lahn, it's a whole other presentation. First, a little bit about neurological disorder and depressive syndromes. Almost any neurological insult will result in depression as a symptom. I don't work in psychogeriatrics, but I've seen 6 or 7 patients over the years who presented with depression in midlife, 3 or 4 years later presented with cognitive decline. Depression as a herald sign of Alzheimer's dementia is well recognised. Depression as a presenting symptom in people who've had an otherwise unrecognised cerebral, for instance, lacuna stroke. I've seen several of those. Multiple sclerosis presenting with the first symptom being depression. I've seen several of those as well. Parkinson's disease, had a patient recently who was referred to me with onset of depressive syndrome in his 70s, with at that point unrecognised Parkinson's disease syndrome, which was evident to me in between the referral and seeing me, which took 6 months for the first assessment to be conducted. His symptoms had progressed and he clearly had a Parkinsonian syndrome. So all these neurological disorders have a very bidirectional relationship with depressive syndromes. Depressive syndromes can be presenting symptoms or epiphenomena of these neurological syndromes. And of course, we know and we see all the time that particularly depressive syndromes can worsen the outcomes of many of these neurological disorders. So there's a strong link between depression and neurology. But what about in eating disorders? There are a lot of brain changes in eating disorders. Substantial grey matter and white matter alterations in patients with anorexia nervosa in particular. Significant reductions in brain cortex thickness, so loss of cortical volume and cortical surface area, often at greater degrees than seen in a lot of other mental illnesses. But with some evidence that these things recover in eating disorders, particularly in anorexia nervosa, with weight restoration over the longer term, that these reductions in brain structure seem to recover, although they can take a very long time. I guess it comes back to implications about early treatment and aggressive treatment to try and treat these patients. Brain's capacity to recover is pretty good. It's better than we used to think it was, but not like that of other organs that dynamically turn over and repair rapidly over time, like the liver, for instance. So there's a lot of things that goes wrong in eating disorders and in the depressive syndromes that are so commonly comorbid. At a neurobiological level, this dysfunction in this sort of reward circuitry, such that food no longer is rewarding in a cognitive and a biological sense. Difficulties with executive and attentional functions, difficulties with interoceptive awareness. So, for instance, the awareness of your internal bodily sensations at a very level, deficiencies in how patients will perceive hunger, and a whole range of other dysfunction in neurotransmitters more broadly in the central nervous system. It is a mess. Depression is very, very commonly comorbid in all eating disorders. There's a lot of genetic vulnerabilities across eating disorders and mood disorders. There's this bidirectionality that the depressive syndrome will worsen the eating disorder will worsen the depressive syndrome. So how do we focus on treating these people? We've got to treat the depressive syndromes as well, assertively. Sometimes that's not as easy as it sounds. We also see these situations where a patient comes in for an eating disorder treatment, such that I treat, ambivalent about the challenge. And if the focus shifts to that of a mood disorder, it might actually take the focus off the eating disorder. And we've seen this recently with a couple of patients. In fact, it was written out actually very eloquently by a patient in our team meeting on Wednesday, who described exactly that relationship. We see these patients who are depressed when they come in at the entry to inpatient care. So they look like they've got an eating disorder. They're very underweight, they're very poor nutrition, they're physically compromised. They all have low mood, generally. They've all got weight loss, they've got anorexia, of course, of appetite. They've often got this anhedonic kind of flair to them. Their sleep's disrupted, they're fatigued, they're guilty, they have poor concentration and cognitive difficulties. I mean, in cross-sectionally, you might say, well, that looks just like a major depressive syndrome. And how is an antidepressant, for instance, going to work in people like this when the brain is so biologically compromised? The distress is really high. The treatment itself of the eating disorder magnifies that distress. There's a lot of expressed emotion from the patient and their family. And most of the time, antidepressant options turned out to be pretty weak options. As we say to many of them, the best antidepressant for them is food. Food and nutrition results in neurological restoration. And it comes back to that biological linkage between the underfed brain and depression. So when might neurostimulation treatment then come into the picture? Most patients get better as we feed them from a depression point of view, but some don't. Some get worse. So they're the patients that we're often looking at in terms of our most commonly applied neurostimulation treatment, which is ECT. For many people, and again, this patient on Wednesday described very eloquently how her eating disorder was a coping skill that helped to keep depression at bay. And here we are treating her eating disorder and apparently making her depression worse. And I've put in brackets there, control is good. It's exactly what she said, but in a more eloquent way. So we're seeing them up close. We're seeing them every day. We're treating them very assertively. They have long inpatient stays, 5 to 7 weeks is not uncommon. So we've got this captive audience that perhaps we should treat more assertively for their depressive syndromes. And you think, wouldn't that be easy? I might also just highlight about how much eating disorders impact on mortality to give further emphasis to assertive treatment. Rates of death generally among severe eating disorders are high, and the highest death rates of all psychiatric disorders, a mixture of suicide and death from commonly cardiac failure or cardiac arrest. So again, I guess it adds weight to the idea that we should treat more assertively. Most of these patients come into hospital, and this is the cohort I'm talking about, this is the cohort I treat, they're already on various medications. They don't seem to be particularly effective. In terms of treating depression particularly, maybe a little bit better in treating anxiety syndromes, which are also commonly comorbid in eating disorders. Most of our patients that we see have a psychologist or have had extensive psychological treatment. They've at least done some cognitive behaviour therapy and sometimes very focused cognitive behaviour therapy for their eating disorder. They've done family-based therapy at home. They've done a bit of dialectical behaviour therapy. Effective across the main, but not often very successful in this group that are failing treatment and ending up in hospital. So we see a cohort that have, and particularly the cohort that we see in hospital, already have had high rates of relapse, high rates of treatment resistance. And both the eating disorder and the depressive syndromes remain very troublesome and problematic. So, should we just treat everything? We've got the treatments available. Let's just go for it. I guess, particularly given that for these patients, they present with these two severe syndromes, an eating disorder and a depressive syndrome. There's a bidirectional relationship between those two syndromes. We're not entirely clear what came first half the time. We're often seeing people with long histories of depression and eating disorders, and yeah, the chicken and the egg is often very difficult to discern. We know too that our patients have high rates of relapse and chronicity. They become harder to treat as they go on. High rates of severe comorbid depression and have high rates of death. And the brain changes may not always be easily reversible. So should we treat everything? Should we really go for it when we've got these patients in hospital, particularly a captive audience, if you like? So I might just go on to talk a little bit about some of the some of the treatments that do fall under the broad category of neurostimulation. So I might start with repetitive transcranial magnetic stimulation. It's clearly not very invasive. It's widely available now. It's now pretty cheap if you qualify under Medicare, and many places will bulk bill for treatments. It's Medicare funded up to a point, 50 sessions in the lifetime of a patient, which is kind of an interesting concept in itself. I mean, initial treatment might be 35 sessions covered by Medicare. The only people who are going to come back for transcranial magnetic stimulation 5 or 6 times a week for repeated treatments for recurrence of depression are going to be those people that actually respond to their initial treatment. No one would put up with the inconvenience of daily treatments over and over again unless it worked. But Medicare only funds 50 sessions in your lifetime. So I think that's helped in some ways bring the costs down. Everyone's competing. There's a lot of providers out there, bulk billing. And now for people who exceed their 50 sessions under Medicare, the cost actually is reasonable. And some of the new protocols for treatment, for top-up treatment, if you like, for relapse, are quicker and more easily administered. So the cost is reasonable for most people. It is inconvenient because it's a daily treatment in an acute course. And it makes me wonder how we might apply that if we did use it here in an eating disorder cohort who are very, very strictly treated and monitored and supervised during their initial course of treatment. We can't provide those as an inpatient. We don't have that facility here. It would have to be done as an outpatient. So that would be a little bit of a practical problem. And for those of you who don't know, it involves repeated high potency magnetic impulses applied to the cerebral cortex. These link to deep brain regions. There is some neuroplastic change and a whole range of other things that happen with TMS. It's been around for a long time now, but the current indication under Medicare is for major depressive disorder that hasn't responded to other treatments. But it is commonly used also in OCD and other anxiety disorders. Has a bit of a role in migraine treatment as well. So what about in eating disorders? Here's this treatment that's pretty safe, fairly side effect free. Wouldn't it be something that you could apply pretty easily to a group of people who have a lot of physical symptoms, who are often medically compromised? Wouldn't this be a great treatment if it worked to apply to that group, if it aided both the recovery from their depression and also from their eating disorder as well? Certainly, some small studies have shown improvements in depressive severity in patients suffering from anorexia nervosa. Also, a few small studies looking at improving people with binge eating disorder. It's not yet approved in Australia under the Therapeutic Goods Administration for the treatment of the eating disorder per se, but you could always make that argument for the comorbid depression and treat under that banner. So, promising. I'm going to whip through a few of the other ones, the other neurostimulation options. Transcranial direct current stimulation. You're going to hear a lot more about this. This one, Flow Neuroscience, recently had a Therapeutic Goods Administration approval for marketing and sales in Australia. And so I made an inquiry on their website. I think they're based in the UK. I've been bombarded with marketing information about this now. I haven't unsubscribed just yet. My most recent email said things like treatment in the safety of your home, painless, as seen in the Daily Telegraph and Sky News. So they're heavily recommended. The marketing is going to ramp up, I think. The TGA has approved its use prescribed by a suitably qualified professional, I think is the terminology, and under health professionals' supervision, whatever that means. Been around for a long time, this treatment. A lot of pilot studies have shown amazing success in all sorts of areas in psychiatry, but bigger studies don't really translate that amazing success into anything that looks clinically useful. But it's painless. You can do it at home, 30 minutes a day. Be very interesting to see where this might sit. As I said, it's approved for a couple of conditions: major depressive disorder, some chronic pain syndromes, and interestingly, in post-stroke rehabilitation. There are already several private clinics offering this around Australia, not eating disorder clinics. These are clinics that treat mood disorders. I said, you know, the TGA somehow mandates it be prescribed and monitored. I don't know how that's going to happen. a constant low intensity unidirectional current delivered between those two electrodes you see there sitting over the frontal lobes. But has shown a little bit of positive results in a variety of eating disorders, although that strength of evidence is not strong. Some suggestion of symptom improvement in binge eating disorder. As I said, I don't know the price, but I suspect it will be cheaper than other methods, pretty tolerable, portable, and soon to be even more available and marketed heavily, I suspect. But the evidence comes from mixed results and small sample sizes. It risks being hijacked, I think, by the periphery or the fringes of medicine. I think that you might have heard of the Perth Brain Centre, which is a clinic run by a chiropractor. Doesn't advertise very strongly that he is a chiropractor. They offer already qualitative EEG and neurofeedback treatments. I understand they're already using this treatment down at that clinic, and they believe that they can treat all sorts of psychiatric syndromes. Not so sure about that. A lot of people get very swayed by their website and their hype. And they've got a variety of people working there who have very diverse backgrounds, and not all of them in health either. So I think that could be something that has a role. I think it risks being diluted because of this this sort of ready availability. Treated, it'll become probably something that's popular on Instagram soon, I guess. There'll be a lot of marketing, soft marketing there. It's probably going to be diluted. It'll probably lose its way. But it's an interesting concept, and there is some evidence from research that it may be applicable in eating disorders, and it's a relatively painless and non-invasive treatment. I guess we have to watch this space a bit. This is deep brain stimulation, I think, is something that may actually have a role, particularly in very severe and enduring eating disorders. It's a lovely graphic, and all these graphics for these sort of neurostimulation treatments are always very beautifully portrayed. It is invasive. It involves a neurosurgeon implanting electrodes into specific areas of the brain, connected to a pulse generator, which, like a pacemaker or a defibrillator, sits just below the clavicle, connected by wires. You can feel them coming out the top of the head, under the scalp, down tunneled under the clavicle to the pulse generator. You may know that similar devices are used quite commonly and almost routinely now in Parkinson's disease, and it's used to some degree in obsessive compulsive disorder as well. There is some evidence that this may actually be an effective treatment in eating disorders. Of course, it's very invasive. It's very costly. It may assist by modulating reward circuits, may improve the motivations for eating and the pleasurable experience of food, and possibly other factors as well around feeding and eating. There are some promising case reports and small case studies, but it doesn't translate into a therapeutic goods administration approval yet for such treatment. I'm not aware of it being done in Australia. My research wasn't able to uncover anything that I'm aware of at this stage. Of course, as I said, it's commonly used in Parkinson's disease. There are some limited numbers of patients across Australia who've had it for severe obsessive compulsive disorder, but I'm not aware of anyone using it in eating disorders yet. I think it could be potentially one of those conditions, if proven to show some reasonably consistent treatment response, could be used in place for people who have the very severe enduring eating disorders, the people that sometimes end up in palliative care and die because of their eating disorder and the consequences thereof. But, you know, very much on the fringes at the moment. Difficult thing to research, unfortunately. It's not easily applicable to large numbers of people given the invasiveness and the difficulties getting the treatment administered to someone. So maybe, as I said, for use in severe treatment-resistant anorexia nervosa, but we need a lot more research and we need a lot more regulatory approvals before we could go down that way. And then we need neurosurgeons who are interested in providing the service. This is another one that gets a lot of run on Instagram, the vagus nerve. We have two vagus nerves, but this is mostly about treating the left side. The right side vagus nerve is a little bit difficult to stimulate because it has a lot of impacts on cardiac function. But vagus nerve is an interesting nerve. The vagus is, it sounds like vague, and it is kind of related to the same root, Latin, presumably. It's meaning wandering. It's the longest cranial nerve in the body. It comes from your brainstem and wanders through your abdomen and down past your heart and everywhere else in between. So it controls a lot of your autonomic nervous system, particularly intra-abdominally and intrathoracic, digestion, heart rate, a lot of other vital organs as well. So why might it be useful? In vagus nerve stimulation, similar thing. You have a stimulator, a pulse generator sitting just below the clavicle and upper chest, wires connected to coils that's wrapped around your vagus nerve, which runs in the carotid sheath in the neck. So it's a particularly fiddly little operation, relatively invasive too. Why might it be useful? So modulating the vagus nerve activity with electrical stimulation has impacts back upwards in the brain, brainstem, and the limbic system. There is some indications for treatment of certain epilepsy conditions and also treatment-resistant depression. It is a bit more widely used in the US. I tried to find where it might be applied here in Australia. I couldn't find it using a simple internet search. But it is a treatment that has been around for a long time as well. The newer devices don't even require surgery. You can actually have handheld devices that you apply externally to the neck to stimulate the vagus nerve. And one of those devices has been approved in the United States to treat cluster headache and migraine. So if there was a little bit more evidence and a little bit more applicability, wouldn't that be an easy treatment if it showed some benefit in patients with eating disorders who are otherwise not responding well to treatment, and also for the treatment of the co-occurring depressive syndromes potentially as well? So it's experimental in eating disorders, can have effects on appetite regulation and mood stabilization, as I just mentioned, but it can't really be recommended at this stage. And we just need much more research to be certain about where it sits and how we use it and who we use it for. But it is promising, and it probably is something for the future, particularly the handheld devices. And now, of course, we move on to good old ECT. Hollywood's a bit of an epicenter of ECT. We do things very well here. Thank you, Brian, for running such an efficient service. It's the most commonly used neurostimulation modality in our inpatient cohort, obviously. Not to treat the eating disorder per se, but to treat the severe and persisting comorbid depressive syndromes in some of our patients. ECT does lots of things. It does so much, it's often hard to sort of pin down exactly where it might be important, but it's a whole brain treatment, really, including deeper grey matter structures. The benefit of a treatment that so impacts on the brain is that it covers everything. Everything's treated, everything's stimulated. Not just turnover of neurotransmitters, but effects on the blood-brain barrier, even genetic expression, and immune system modulation. So there's so much that happens. ECT is relatively non-invasive, but it's tricky, it's complicated. It takes a while to set it up, requires a lot of staff to administer, requires a specific consent. It's a little bit of a palaver to get going, but once it's going, we have a system that runs well, like clockwork. So I always say again that the best antidepressant for an eating disorder patient who's underweight is adequate regular nutrition in the form of food. And most patients improve in their mood, their cognition, their personality. We see patients start to smile and develop their sense of humor and become witty again. Their mood improves, their ability to tackle treatment usually improves with it. Treatment for the eating disorder, that is. But we do have a small cohort of patients for whom a severe depressive syndrome persists despite adequate refeeding or emerges with adequate refeeding. And this is often more readily obvious to us 3-4 weeks down the track. You know, that sort of time when many patients who have successfully negotiated an eating disorder admission are actually, we're starting to think about discharge planning. And then we have some of these patients who don't seem to be able to participate in discharge planning. Their eating disorder treatment has been compromised by their persisting or emerging depressive syndrome. And we start to think about, well, what else is necessary? These patients are usually on a whole heap of antidepressants and other things as well. But as I said, I'm a bit skeptical about the role of antidepressants in eating disorders generally. So when do we turn to it? Well, when food hasn't worked, depression's more severe and persisting or emerging and severe. Some patients prefer it. Patients who had ECT before, it's demystified for them. They will sometimes say, can I have ECT? They are interesting, and sometimes you don't even think that ECT might be useful, but they're asking for it. So that's a difficult discussion sometimes. But you know, it increasingly is destigmatized and demystified for people. So it is something that generally we can turn to if required, once relative medical stability is established. So some practical considerations. We have patients as young as 16. Under the Mental Health Act, consent for 16 to 18-year-olds is a very complicated procedure, and administering ECT is a very difficult process. Luckily, we haven't even had to consider ECT for anyone who's a minor at this stage. Family concerns are often quite significant. This is a group where there's a lot of enmeshment, a lot of expressed emotion, a lot of family involvement, a lot of angst at failed treatments, and often a lot of misperceptions and concerns about ECT expressed from family compared to other patient cohorts. So there's a lot of work to be done there with families to educate and reassure, probably even more so than with the patient themselves. In our cohort, and we probably give ECT a couple of times a year to recovering or just recovered eating disorder patients, we've got a few issues we need to consider. Many of them are on benzodiazepines as a pre-medication before meals, as well as other PRN benzodiazepines, as well as regular benzodiazepines. So we have to consider limiting that to enable ECT to proceed as easy as possible. These patients have delayed gastric emptying, reflux, constipation, a lot of GIT disturbance. That takes a long time to resolve too sometimes. So that's certainly an issue in consideration for the anaesthetist, particularly in and around ECT and I guess the risk of potential reflux and pneumonitis that may come with that. Fasting issues are obviously difficult to manage in patients with eating disorders, and some patients indeed find that very difficult. So we like to have our eating disorder patients who are having ECTs to be first on the list to minimise the fasting period. That includes patients who are having nasogastric feeding, usually overnight, but sometimes 24-hour feeds. We need to turn those feeds off several hours before ECT to make sure that the stomach is empty, minimising the risk of reflux and esophageal and pneumonitis that may occur. We've got to make up their feeds afterwards. We don't want patients who are eating precariously to miss meals and supplements and snacks. These are patients, obviously, who are in a very highly structured program. They've got a lot of difficulty managing any missed meal is seen as a bonus to many of them and can destabilise their treatment progress. So we need to make up their meals and snacks and supplements in the period after ECT. It's always a bit easier if they're first on the list for ECT, which starts at 7:30. We still need to monitor electrolytes. We do see most of those electrolyte abnormalities which convey cardiac risk. Generally, we see a lot of those electrolyte abnormalities early on in the admission. They tend to normalise by the time we get to ECT, but it still requires some sort of monitoring. There are also, some of our patients with more severe eating disorders have had quite significant cardiac dysfunction at times. We certainly monitor cardiac function regularly. We do ECGs on everybody. Nearly all our patients get an echocardiogram of their heart if they haven't had one in recent times. We will sometimes do Holter monitors when 24-hour ECG Holter monitors if patients are complaining of palpitations or other symptoms that refer to cardiac rhythm disturbances. So we generally have a lot of information there to assist the anaesthetist in assessing whether someone is physically up to the demands of ECT. We also see some patients very early on, even in their life, in their early 20s or sometimes in their late teens, who have osteopenia or even osteoporosis and actually have histories of pathological fractures from minimal exertion. So that is a little bit of a risk in ECT, and it's something that the anaesthetist has to take into account. We've often done bone scans, bone mineral density scans on our patients if they haven't had them done in the recent past. We have an idea about where they sit there, and that can assist the anaesthetist in planning for the use of muscle relaxants and anaesthetic agents during ECT. So I guess summing that all up, I guess neurostimulation options are a promising adjunctive treatment for eating disorders. There's so much more research that's needed though. ECT sits pretty easily in the treatment, particularly for severe comorbid depressive syndromes in anorexia nervosa. We've kind of figured out how to do that fairly safely for our patients and reasonably routinely on those patients that do seem to require a higher level of depression treatment. TMS shows some efficacy in eating disorders and non-invasive, but it's just a palaver around delivering it daily, 5 days of the week or 6 days of the week for patients too who are inpatient, very regulated treatment, very heavily monitored. That's a difficult thing to do unless we had a TMS machine on site, and we don't. That might increasingly, if research assists us to see where it sits, it might, and how we select patients for TMS, that might assist in the treatment of both the depressive syndromes and the eating disorder syndrome in our patients. I think deep brain stimulation probably needs a look in, increasingly looking for those people with really severe and enduring eating disorders, particularly people with anorexia nervosa, who obviously everybody's going to die young, and sometimes they even end up in palliative care because of impossible to treat anorexia nervosa syndrome. Deep brain stimulation may be a treatment of last choice, but there's a lot of regulatory barriers and research barriers yet to recommend that. The place of transcranial direct current stimulation remains unclear, but will increasingly be used by patients, I'm sure, and we'll increasingly have to encounter patients who are using it. And I guess I can't wait till that time someone comes into hospital for treatment their eating disorder and brings their direct current stimulator in with them. And what do we do then? Vagus nerve stimulation, not really on the radar currently, but does offer some promise. And if the non-invasive forms of vagus nerve stimulation can be researched more thoroughly and see where they sit, may offer an easy to administer adjunctive therapy for both the eating disorder and the comorbid depressive syndrome. Lots of ethical, regulatory and financial challenges ahead. Some of these treatments are very expensive, like deep brain stimulation. Some of them are just difficult to access. Some of them don't have regulatory approval. Many of them don't have a solid research basis. Comes back to ECT. ECT we use quite routinely for severe depressive syndromes. We use them in people who have comorbid eating disorders, and it remains an effective treatment. So we need a lot more guidance about where these treatments might sit. I might be retired before they become part of routine clinical practice. Maybe some of them will, maybe some of them won't, I don't know. But I do think treatments like TMS, deep brain stimulation, and possibly vagus nerve stimulation have a bit more to offer once we're a little bit clearer where they sit. So I hope that gives you a little bit of a broad summary. It doesn't answer too many questions, but it raises a bit of hope for the future, I hope. And I'm happy to take any questions if anyone has any.
Excellent. Any questions from now? What was you compare sort of success rates from your sort of non-eating disorder patients in ECT? Would you say it's comparable, or eating disorder cohort?
I think, this big Swedish cohort that looked at people who had ECT in Sweden over many years and then looked at what the outcomes were for the eating disorder versus the non-eating disorder patients showed that everyone tolerated about the same, but the eating disorder patients were slightly less had slightly less response rates. So I guess that feels like what we see. Yeah, we see this sort of just feel a little bit less optimistic about the outcome for ECT in our patients with the co-occurring severe eating disorders. But still an effective treatment, but possibly I guess if you've got your brain as your substrate for ECT is starved and underfed and has all sorts of other biological things going on, then obviously they're not really going to perhaps respond to ECT the same way to someone with a more of an uncomplicated melancholic depression, perhaps. So,
and that fits. I think the data says have a common anxiety disorder of any kind or a personality disorder needs to response rates out of that much less the low person with psychosis than negative. TMS later.
Yeah, be nice, wouldn't it? We had it.
So we've got an open dialogue with Greg Price. This is a artist that Charlie's and Dr. McAndrew.
Is it?
Is it? Yeah. So
or does Salam Hussain have something to do with it as well?
So we have actually had sent patients across the TMS. They walk themselves across, no questions asked. They're not charged and they continue as an outpatient. So that's happened once or twice. So there is a sort of a connection.
Is there much difficulty in negotiating this with the public system?
Not at all.
Would be a little complicated in our cohort who has such a highly structured approach to treatment to then walk them over 5 days a week, stay with them, walk back with them. They're not the sort of patients we would leave unsupervised at this stage of treatment generally. And to go on for 5 weeks or 7 weeks or something like that, it could be a tricky option. It'd be nice if we had something in-house. And if there was a strong evidence base, then why not? Non-invasive could be fitted in the morning or the afternoon. Could be really useful once we had a little bit more solid evidence about who would benefit from it and when.
TMS machines in the store.
You could do more liaison with the brain centre, of course, later. We've got lots of machines, and it'll be interesting expertise. Perhaps I can just broaden out the conversation a little bit. In that, thank you very much for highlighting the biological treatments for eating disorders, which I've worked with eating disorders since the early 1990s. It was very much dominated by the psycho and the social, with the only bio really being food. But no, I used to go to a lot of these eating disorder conferences, and I'd occasionally raise the concept of bio, a medication or whatever. And if I was giving a lecture on it, the room would empty. The psychologist.
You'd be shouted down, Roger, or quietly shouted
It's
down.
not very politely, not very popular. But it's coming back, and it's coming back in the area of mostly reward pathways. And I was alerted to this many years ago, late 1990s. I was treating my ADHD patients and giving them stimulants, and I said, when they came back to follow up, how's the concentration? Oh, much better, thanks, doc. Anything else? By the by, doc, I've stopped binge eating. Oh, I said, that's interesting. After 20 or 30 or 40 patients said the same thing, I thought there might be something in this. So I began treating my binge eating disorder patients and bulimia nervosa patients with stimulants, off label, of course, and mostly for depression, as you say, it's mostly comorbid. And I was struck by what they said. They would say, because I said, oh, it's just blocking your appetite, is it? No, they said, I'm still hungry, but the cravings for binge eating have reduced or disappeared, sometimes overnight, like miraculously. And I thought, that's interesting. That was the late 1990s. And I assumed research around the world would produce something within 5 years or so, but it didn't. There's only one guy working in the field on this, guy called Aaron Keshen in Halifax, Nova Scotia, who about 10 years ago explored the field, got howled down, and is now still tentatively trying to push forward in showing that stimulants might be useful in bulimia nervosa. As we know, the TGA has allowed them for binge eating, allowed Vyvanse, but all the stimulants are useful, gets amphetamine. But it's not allowing for bulimia nervosa. And the universal worry was that if you treat patients with bulimia nervosa with stimulants, they'll develop anorexia nervosa. I never saw it. But even so, there was a resistance to the whole field.
Perhaps it's untreated bulimia nervosa that might be more likely to become cycling through other forms of the eating disorder, anorexia, or mixed disorders. Perhaps treatment actually might stop that. Perhaps you think got to twist it around, think of it the other way, like you're thinking about it.
Maybe so. The whole field of biology in eating disorders is now opening up. I think that's a great thing. Neurostimulation, psychedelics. There's some trials now in psilocin in binge eating disorder, ketamine, all based around the reward, trying to interrupt negative cycle type thing. I mean, to interrupt those negative cycles, you can interrupt it with ECT or neurostimulation or long-term therapy, trying to interrupt the behavioural. It's very much an addiction model that you're dealing with. Having run the eating disorder program here from 1997 to 2011, it was only when I stepped back from it, I thought, I was tackling addiction. That's why I got burnt out. It gets you in the end. It's very difficult.
Yeah, I often use an addiction model to reference things to the patients.
Very much a motivational enhancement. So I think that's the future. We need to get, as well as the psych and the social, which are terribly important, to up the bio, because I think that's where the breakthrough is going to come. They're already coming for binge eating, but if they could come for interrupting that addiction to that low calorie state, then we're onto something, I think.
Yeah, well, the brain changes are dramatic, actually, compared to other psychiatric disorders. The biological changes in brain are quite dramatic in established eating disorders. So there's something going on there, clearly very biological. And whilst I'm not dissing the psychological therapies and all the support therapies and everything else, I mean, there seems to be logically a place for strong, effective biological treatments to get people across the line and get them back into remission. And then it's like treating severe depression. In some sense, once you treat severe depression pharmacologically, if you can do so, the psychological therapies have a greater role, the patient can engage better, and maybe you see that greater impact on relapse prevention in the longer term from the psychological therapy. These starved patients who come to hospital can't engage in anything except strict behavioural stuff. Antidepressants don't work often, and we need something better and stronger. Yeah, interesting about the stimulants in binge eating disorder and in bulimia nervosa. Yeah, very strong effect size. Yeah.
Well, it's fascinating now. I was just reading recently about the GLP-1s, the anti-obesity drugs, which now seem to be working on the reward addiction model as well. So as well as decreasing the cravings for eating, the patients are saying, actually, I'm not drinking so much alcohol.
No, see it all the time.
I'm not compulsively shopping. I'm not gambling so much. Well, that's interesting. And so they're doing some trials now with binge eating and finding some positivity, even with anorexia nervosa. Now, that's interesting.
That would be.
You know,
That would be a regulatory hurdle, hard to cross, wouldn't it? We're going to put an appetite suppressant for the anorexics. Yeah, it would be very interesting. And that thing about certainly patients on GLP-1 drugs always mention they just don't feel like drinking anymore. I hear that almost universally. Interesting. There's a lot more things to go. A lot of research. Some of these research, I can't imagine how the proposals, some of these research, there's so many elements and so many contexts and so many parameters. These are hard things to research. These are hard diagnostic groups to get into research for a start. I imagine the ethical considerations and ethics committees' ruminations about whether to approve things would be really, really tricky. But I'd certainly like to see a little bit.
It's a life-threatening condition, and your chronic patients are heading towards palliative care. You're likely to get approval for the most weird and wonderful things. You've got to try something. Within reason.
Yeah. No, I agree. So there's lots more in this space to come, that's for sure. This is the tip of the iceberg, really. So we'll see things come in years to come, I'm sure.